Just about everything that we are going to talk about in this lecture is going to be things that you will see on the CRC exam, and it's very applicable to your daily life as a risk adjustment coder. So you need to pay attention. You can come back and reference this video as many times as you want, but know that everything that we talk about in this lecture is going to be important. It is the basics, or better yet, maybe we could even say that it's the foundation of what you're going to need to know about risk adjustment. So let's move forward and jump in. We have to know what risk adjustment actually is. You don't necessarily need to know the dates with risk adjustment, but it is applicable in understanding how risk adjustment has changed as it is changing. Ultimately, what risk adjustment is a way for the insurances or the payers to be compensated. In the past, it has always revolved around the CPT codes for reimbursement for our providers from the payers or the insurance companies. But with risk adjustment, as a general rule, it's a little bit different. It's based on the ICD codes, the diagnoses. Now, way back in the beginning, when we started working with, I wouldn't say commercial medicine, but you know, if you go way back, you had doctors and they could be paid with money, or they could be paid with a chicken, or you know, you didn't know how they were going to get paid, but they were going to be reimbursed, and they were reimbursed for the work that they did. And it makes sense that the sicker that the patient was, the more that they would be reimbursed, right? Just because they would take more care. That's kind of how risk adjustment worked. As we moved forward and commercialized everything, risk adjustment wasn't as important. They didn't think that way anymore. They assigned codes, or CPT codes, for what the providers do to the patient. So if I'm going to clean out the cerumen in your ears, I get X amount. You're not getting paid because they have cerumen in their ears. They're being reimbursed because of what they do to remove the cerumen, right? And then as they, you know, if I'm going to do an appendectomy, I get paid for an appendectomy, but I get paid differently for a laparoscopic appendectomy versus an open appendectomy, right? The way risk adjustment works is a little different. It's not what you're doing to the patient, but what's wrong with the patient. And we're going to give lots of examples. So let's go back to the appendectomy. The provider does an appendectomy. However, an appendectomy on a healthy 16-year-old is going to be a lot different than an appendectomy on a 65-year-old patient that also has diabetes and PVD, right? And that's where risk adjustment starts playing a role. It pays attention to the diagnoses and how sick the patient is with comorbidities versus what is actually being done, because it's understood that a plan of care is regimented for specific diagnoses. Back in 2017, there was actually a statistic that showed that because of the Affordable Care Act, the ACA, that we had more people enrolled in MA plans, Medicare Advantage plans, and Medicare Advantage plans risk adjust. That's how they set aside money to know what they need in the future to care for a patient. And we'll talk about that a little more in depth. And again, these assessments, or these the risk adjustment, is based on ICD. Therefore, your knowledge of diagnoses and the disease processes, the comorbidities, the treatments, the differential diagnoses, all of that is something that is going to be very important in your knowledge bank, in your skills when dealing with risk adjustment. So very, very heavily focused on diagnosis and the guidelines that follow that. Because diagnosis is that cornerstone of what we're doing in this foundation of knowledge that we're talking about, that means that you need to be your coding skills. You're not going to deal with CPT codes. You're going to deal with ICD codes, right? And they are mainstream coding. You know, everyday coding is going to be based on CPT code still. Now, eventually that tide will turn and you'll see how risk adjustment does play a part in other outpatient coding. But for the most part, right now, the weight for diagnosis really falls on hospital payments. They use diagnosis codes to be reimbursed, not what you do to the patient. They don't use CPT codes. They use ICD-10 PCS codes, which are procedural codes that are somewhat similar to CPT in that they say what procedure is being done to the patient, but that doesn't carry weight for reimbursement. You do need to know what CPT codes are, but you will not use CPT codes when you do risk adjustment coding, right? So everywhere else in mainstream coding for outpatient and even ancillary services and hospitals and stuff, they're going to use CPT codes because those are the money codes. Well, because it's been that way for so long, people think differently when they look at it from what I call a mainstream coder's view versus the viewpoint of a risk adjustment coder. It's a completely different hat, okay? And I'll bring that up as we go through these lectures. So if you already are certified as a coder, maybe you have the CCS through a HEMA, maybe you have the CPC through the AAPC, maybe you have a credential through QPro or one of the others. You know, you understand how CPT works. Even if, like with the HEMA credential, we think of CCS as inpatient hospital coding. It is used a little bit. You need to be aware of it, but nowhere else do you strictly focus on the diagnosis except for in risk adjustment. The thought process when we do coding in the outpatient world, we always think about that CPT code and why the patient was being seen for that day. And that's the way the encounters and the documentation is written. That's the focus. The focus is not on comorbidities that change how the patient's going to be treated. Again, the example of the appendicitis in a 16-year-old healthy patient and a 65-year-old patient that has comorbidities, right? So they definitely will be treated differently. Let's look at these two patients. And this is another example, like the appendicitis. Patient A, they've got the flu and they've got pneumonia, influenza and pneumonia. They're 35 years old. They don't have any other chronic conditions. They're relatively healthy, okay? Then you have patient B, same diagnosis, new diagnosis of influenza and pneumonia, except this is a 72-year-old patient and they have comorbidities. We have type 2 diabetes, we have chronic bronchitis and emphysema. Now, just because you understand the disease process, you already know the treatment for the patient A is going to be different than the treatment and the plan of care for patient B. They have the same diagnosis and they are both newly diagnosed, but there's factors, their age, right? Their comorbidities, all of that plays a part in how much it's going to cost to treat the patient. They'll be treated the same. They'll probably be put on the same antibiotic. The plan of care will somewhat be the same because we know the disease process for influenza and pneumonia. However, the plan of care is going to be different ultimately for patient B because of how diabetes works, how bronchitis and definitely emphysema works in that patient. From the inpatient standpoint, it makes sense because it's diagnosis based. But from an outpatient standpoint, it does. All we're looking at is, the pneumonia and the influenza and nothing else, right? So again, it's two different mindsets. So I want you to think for yourself here, take a moment. If you have to, pause the video and write down in your notebook on a piece of paper what you think, is going to be the plan of care for your 35-year-old patient with the flu and pneumonia, and what that is going to be for our patient B. Some of the main things to think about is what's the recovery time for patient A versus patient B? Well, definitely patient A is going to be expecting, we would expect they would recover faster, right? Whereas patient B, diabetes, first thing we know about diabetes is you don't heal well, right? The medication that you give to treat pneumonia is often a steroid. So if we put both patients on prednisone, how is the patient with A going to react versus patient B? The reaction is going to be significantly different because prednisone or steroids affect your blood sugars. And you're going to have a type 2 diabetic, and knowing if they're on insulin or not makes a difference as well. But it's going to change their blood sugars. It's going to raise their blood sugars. Whereas prednisone isn't going to affect patient A at all, except for to make them feel better, right? Take the inflammation out of the lungs and help dry up the fluid that's in the lungs. Whereas it's going to do the same thing for patient B, but it's also going to raise their blood sugars. So they're probably going to have their insulin or their medication adjusted or at least tracked, right? If we have chronic bronchitis, that's a chronic condition that has led most likely to an additional diagnosis of emphysema. If they're on emphysema, I can guarantee you they're on oxygen, right? Patient A is not on oxygen, overall healthy. If a patient's on oxygen and has pneumonia, how is that going to affect their plan of care? How's it going to affect their ability to heal? Diabetics don't heal like other people. Chronic condition that's obstructive, chronic bronchitis, their bronchial passages stay chronically inflamed, and that makes them more susceptible to the bacterias and viruses, because you can have viral and bacterial pneumonia, as well as emphysema is actually a change in the anatomy and the structure of the lungs, right? You don't get better from emphysema. And so again, two different patients, but they've got the same diagnosis, and their plan of care is going to be extremely different. And as we look at that, from an outpatient perspective, same diagnosis, and it doesn't seem that different. But as we risk adjust and plan for how much money do we need to set aside to pay for patient A versus how much money do we need to set aside for patient B, significantly more money needs to be set aside for patient B. Let's look at, well, here I've already told you the changes that risk adjustment makes in the disease process, but the comorbidities, if they're not documented when a patient comes in, so patient A goes and sees their PCP, and there's nothing else wrong with this patient. Patient B comes in and sees their PCP, but let's say chronic bronchitis, emphysema, and diabetes isn't mentioned as comorbidities. It just says they have pneumonia and influenza. Therefore, Medicare, who's taking care of the 72-year-old patient who's paying the bill, they can't determine, set aside how much money it's going to take care of that patient, because they don't know the comorbidities. And that's where the risk adjustment coder comes in. Right? We have to have all of the diagnoses and when we're dealing with risk adjustment, as well as knowing that the patient's 72. Just knowing that the patient's 35 versus 72, that right there should tell us, a 35-year-old is going to recover from pneumonia faster than a 72-year-old. So it's not just the diagnosis, but it's the dynamics of the person's condition as well as other factors. What happens is, for risk adjustment, we come up with a risk score calculation. You need to know all of these terms. Okay, so I want you to be able to make sure that you write them down. You can reference them in your text, and I would say you need to have them memorized. Okay, so MSDRGs, that is what you use for risk adjustment to pay for hospital bills, okay, and surgeries that are done. Ultimately, it is going to track any coexisting chronic diseases that are in a Medicare patient. And they do some private payers too, but ultimately, MSDRGs is going to calculate out hospital. So you don't do MSDRGs in outpatient. Then you have CMS CCs. Now, a lot of times with risk adjustment, you'll hear the term HCC. You'll hear people say, "Oh, I do HCC coding." Well, that would be jargon for people that do this all the time, because it's easier to say HCCs than to say risk adjustment. It doesn't roll off the tongue like HCC does. But you're really not doing HCC work, you're doing risk adjustment work. So when you go to look for a job, you're not going to look for HCC coder, you're going to look for risk adjustment coder, because that's the proper term. And I always think, when I tell people about this, I think of how regionally verbiage is different. So if you go to the East Coast, if they have a drink of soda or soda pop or cola or Coke, they all call, everybody in all the different regions, the East Coast, Southern, the West Coast, Northerners, they all use something a little different to refer to what they want. And it was very funny that when we moved to Texas, they would say, what would you like to drink? And the person would say, "Yes, I'll have a Coke, make mine a Dr. Pepper." It's because they use Coke synonymously with all soft drinks, not a soda pop or a sody or a soda, and that's kind of the way it is with the verbiage for risk adjustment. HCC is what you'll hear when people talk amongst themselves, but that are in the risk adjustment business. However, the proper term is risk adjustment, and that's what you'll see when you're tracking it. So keep that in mind. CDPS, you do need to know what that stands for, and really what you're doing is this is chronic illnesses or disability classifications that are programs that fall under Medicare. This is how we adjust the payments to the insurance companies, which are the payers. And then you also need to be aware of the ACA, the Affordable Care Act. Now, right now, don't feel bad if your little spidey senses should be going up and say, "Hey, wait a minute, what if they get rid of the ACA?" Well, they could get rid of the ACA, so don't worry about that, because it's not going to change some of the laws that have already been established. Like, they're not going to take out pre-existing conditions, and the ACA actually plays a huge part in implementing risk adjustment. Several of the laws that were written into the ACA were good laws that tell us how to set money aside for risk adjustment. So again, you need to be aware of those terms. Ultimately, there's a two-pronged goal. What we need to do, we need to make sure that we are getting proper insurance coverage for the patients, How are we going to do that? Based on the diagnoses. How do we get the diagnoses? From the documentation. How is it converted from the documentation? Well, it's done by coding and regular monitoring. And so every year in risk adjustment, you will be monitoring and coding out the documentation for the previous year, trying to get the diagnoses so they can project what they need to set aside for that patient in the next year. Right? Also, you are going to, with risk adjustment, you want to just accurately track everything that's happening to that patient, right? So that we make sure the requirements for the care of that patient are going to be able to be met in the future. Okay, so we're predicting, we're looking at the past, a previous year. We're collecting from the documentation every diagnosis, at least every chronic condition, and sometimes you will do complete captures where you just capture every diagnosis. It just really depends what who you're working for and what your role as a risk adjustment coder is, because it's not just working for MA plans. And even with MA plans, they have different contracts and things that you'll be doing. So one person might say, I'm a risk adjustment coder, and you're explaining what you do to somebody else, and you say, well, I collect diagnosis codes, chronic condition diagnosis codes. But ultimately, it's all diagnoses that you're paying attention to, not just the chronic conditions. But that's what we usually think of mostly, is those chronic conditions because of Medicare. We also want to know which patients are risky patients, because with risk adjustment, if talking about patient B, that's a much higher risk patient than patient A that we saw, because the emphysema and the diabetes, right? So automatically our brain should go to what's the disease process with these comorbidities, and what's the plan of care going to be, and what is the ultimate outcome. So a patient with emphysema and diabetes has a higher probability of death from influenza and pneumonia than a 35-year-old otherwise healthy patient, right? And that we don't want that to happen. Now, before the Affordable Care Act, we know that was one of the components of being able to cover patients that were at high risk, because in the past, if you were high risk, they would just drop you because you cost them money, right? And the Affordable Care Act took that away. And so with all of the things that people complain about, the pros and the cons of the ACA, and that's not what we're talking about here, there are some things that they put into place that are very, very good components, which is ensuring people that normally would not been insured or could have been dropped, and keeping those premiums affordable, both for Medicare as well. Well, if you're a provider or a coder, what's that actually going to mean to you then, as in working with risk adjustment? Well, from the coder's standpoint, I already alluded to this, we will be looking at the documentation and abstracting out the chronic conditions or all diagnoses, right? And trying to figure out not just why the patient was seen there that day, but their condition, and if it is a current condition or diagnosis that will affect them in the future. Therefore, our documentation has to be very specific. And as a regular outpatient coder, our thought is, and the way we're trained is, you only code for the diagnosis that the patient's being treated for that day. Right? That's the way we're trained as a coder. However, the providers are also trained that way. And so they don't necessarily write these comorbidities in or document them if in fact they're not affecting the diagnosis, or they aren't applicable to a patient that is being seen that day. And the only one, that I can think of that, for example, diabetes wouldn't affect is maybe the cerumen in the ears. What diabetics, it's not going to make a difference. But if a patient has diabetes, it needs to be documented every time a provider sees that patient, because it affects anything that happens to that patient. And there's other conditions like that, but that might not be, because that's not the way providers or physicians are trained. It needs to be accurate. It also needs to be clinically valid, right? And this is where we get into things being, document specialists work a lot on this, and medical decision making, right? That's a big term that us coders have to deal with when we especially work with E&Ms. And it has to be unambiguous. That means that there's no gray area. We need to have black and white. The patient either has diabetes or they don't have diabetes. Well, even though it may say past conditions, it says diabetes. Do we cure diabetes? No, right? But if it says past condition, the legal document states this is a past condition, right? Not a current condition. And so, that needs to be documented that it is a current chronic condition. We're not curing diabetes anytime soon, although you do make exceptions for people that have had gastric surgery. If they have type 2 diabetes and they have gastric bypass or sleeve, that will get rid of diabetes, but that's a rare exception. So what does the coder need to know? They need to know the guidelines. And I can guarantee you that your providers, unless they've been trained as coders, and thank the good Lord for some of them that take that extra time and initiative to be trained, because actually they get reimbursed better because they understand how they're being reimbursed. But they're not trained to follow the guidelines. And right now with EMRs and them working in the EMRs, they'll do the drop down and say, yep, the patient has diabetes, but there's a different code for diabetes with comorbidities, right? We understand the guidelines, but they don't. So providers aren't coders. We do the coding. And an EMR is not going to replace what we do. We have to make sure that we're accurate and we assign the proper code. I can't tell you how many times I've looked through charts, because you're looking at a year's worth of documentation, and I've seen encounters of patients that were HIV positive, but they were coded as AIDS and they didn't have AIDS. That will mess with statistical statistics that we check, and we do our coding because of statistical reasons, and therefore risk adjustment is actually capturing statistics. We want to always get to the highest specificity. So a person isn't just a diabetic. Do they have any comorbidities? Absolutely, that has to be listed. And we want to be complete. So we want to be very thorough. So the records have criteria, and our job as risk adjustment coders is making sure that the records, if we're working with a provider and we're not working for an MA plan and we have contact with those providers, we need to help educate them in the proper way, not tell them that they're doing something wrong. But part of our role is, as a document specialist, saying, this is the specificity I need to be able to do the risk adjustment assessments and coding for your practice. This is what Medicare looks at. And it's not just Medicare now, because we have HHS, right? HCCs. We'll talk about that in a moment too. So many terms. So why isn't that happening now, right? Why are CPT codes historically what we use for reimbursement versus the diagnosis codes? And again, that it's been that way for a very long time. The AMA came out with the CPT codes. They realized that not only could they collect statistics that way, but they could, it's a convenient way to get paid. And so that's what they went with. However, the pendulum is changing, and I foresee, in my humble opinion, CPT is going to be used less and less and less as we go into the future of risk adjustment. Things are going to, right now, Medicare, the biggest insurance payer in the United States, uses risk adjustment, okay? And whatever they do, the state level, Medicare does. And Medicare now risk adjusts because we have HHS, HCCs for risk adjustment. And whatever they do, the commercial insurances usually adopt and start practicing, and they have, especially now because of the ACA and them being federally funded, right? Even if they take away that federal funding and they get rid of the ACA, it doesn't matter. This is a model that works because it's a budget. And everybody knows when you're dealing with money, you need to have a budget. And CPT does not budget. You don't risk adjust and plan ahead with CPT. You're just getting your dollars. Physicians aren't trained in diagnostic coding, right? They're trained to diagnose, but they're not trained in diagnostic coding. They don't know the guidelines. They don't know the rules. All they know is the CPT and what gets them paid. That's why they learn that. And as you may or may not know, depending on if this is new to you as a coder, diagnosis coding can be very intricate. There's a lot of guidelines, and you have to understand the disease process, or a lot of it won't make sense. For me, I'm a diagnosis specialist. I absolutely love ICD. So again, that's what I thrive on. But somebody that has that CPT background where that's what they thrived on because that's what everybody talks about, that's how you got paid, it's a little bit different for them, right? The ICD backs up the CPT, whereas now CPT doesn't even matter to a risk adjustment coder. Let's give you some examples of how a diagnosis code is different than a CPT code and the documentation is needed. And why CPT doesn't necessarily explain the full picture and ICD does. Okay, that's what this example is. So we have a physician, let's say, I always like to say Dr. Feelgood, he's going to make you feel good. So a patient comes into Dr. Feelgood's office and they're going to have their annual exam, and there's no abnormal findings at that time. That's a Z00.00. That's that famous zoo code that we learn when we learn to code, right? When we learn about when you're going to take the CPC exam or just general coding, you learn that zoo code, very commonly used. However, the medical necessity in this is different. If there is nothing going on with that patient that day when they have their yearly exam, they're probably not going to capture any chronic conditions or comorbidities because they're not sick. Okay, they just went in. It's not, let me correct what I said a minute ago. I said your annual yearly exam. Okay, let's not say that because they'll say they want to know everything that's wrong with you, right? Whereas if you're just going in to be seen for a regular visit, a zoo code, that's not an annual exam code. I'm sorry, I made a mistake. Then they're not going to talk about you having diabetes or hypertension if that's not why you've been there. So I'm having problems with my ears. I'm a little dizzy. I'm having trouble hearing. I'm worried that I might be losing my hearing. I go in and the doctor sees all that wax and buildup in my ear. It's itchy. I hear clicking and crackling noises, and he cleans out my ears. That's a zoo code, Z00.00. No really abnormal findings per se. Are they going to talk about me having hypertension? No. Is it pertinent to me having diabetes? No. What about asthma? No. So nothing was captured. Okay, now let's look at a code of K70.30, and you think, okay, we got something here. We have alcoholic cirrhosis of the liver without ascites. Okay, that's fine. That you think I can capture that? Yes, cirrhosis of the liver does risk adjustment. However, so does the alcohol abuse and dependence on the alcohol. it's not going to change the value of the risk adjustment payment. Okay, but we need to be aware of that for statistical purposes. So again, you have to be able to capture all of the codes that are pertinent for that patient. Extremely important. Now, there is some new initiatives in Medicare. They've been around for a while, this MIPS, and you'll read more about that in your text, but it's value-based payment modifier program. And it's going to change a little bit about how we're paid, in that it's quality and also the cost of care given to a patient for a specific diagnosis. Now, that's what we normally do with risk adjustment, but it's going to give penalties and bonuses to the provider, right? So here a while back, if they started an initiative with Medicare that, if you could, preventative medicine, if we can get the patient to take these preventative medicine steps and we make people healthier earlier, then it'll cost Medicare less to take care of them. So therefore, we want you to have your colonoscopy. We want you to have your mammogram. We want to have your prostate checked. These are things that are preventative measures that if we capture a problem early, it's a lot more effective and cost effective to treat something early versus wait until you have prostate cancer or full-blown prostate cancer that's metastasized to the lung, right? So again, mammograms, we want to capture that before it starts, or if you're at risk early. So they would give bonuses. So for example, let's say that every time a provider got a Medicare patient to go have a colonoscopy, they would get an additional $50 bonus, okay, for a specific year. So again, that provider was bam, bam, bam. Have you had your colonoscopy? Can I schedule that for you? Follow up. Did you get your colonoscopy? Or I got your, your information. They'd send out postcards. Don't forget to schedule your colonoscopy, because they would get a bonus if they could document that they got the patient to go get their colonoscopy, right? And just the documentation that they were pushing it, discussed with the patient the benefits of having a colonoscopy, and it was documented. Then they're saying, see, I did that part, and they're going to go get their colonoscopy, and so we get a bonus for that. They did that for a while, and then they said, okay, now that you're in the habit of doing that, if you don't continue to do that, if your patient doesn't get a colonoscopy, then we're going to penalize you, and we're going to take $50 out of your paycheck instead. That's the way Medicare works. So again, they want you to have your patient do these things, and so it's their way of both training the patient and the provider to have these things done. Again, they want to know the difference. They want documentation and to be able to give resources for things like diabetes, but also diabetes with complications, right? You need to be getting that diabetic patient out to the podiatrist. Let the podiatrist follow with the toenails and making sure that the feet are healthy so that we don't get any gangrene or ulcers in the toes or any complications. How do we do that? Ultimately, what the purpose of this was is for them to do better at documenting, to get the patient to do it as well as, and the provider, but get the documentation improved. Being a document specialist just comes hand in hand with being a coder. All right, now let's look at the risk adjustment models and how that works. In your everyday coding, as maybe in risk adjustment for an MA plan, you won't really think about how the scores lay out, but as a CRC, you definitely need to understand how the score is laid out. It may not be a part of what you do as a risk adjustment coder, or it might be, right? But you still have to understand how the model works. So let's talk about that. The first thing you have to know is that, again, Medicare is the largest payer in the United States, right? They insure the most people. And you can get Medicare if you are 65 years of age, or you have end-stage renal disease, and now that's the way it used to always be, and now there's some other conditions that will allow you to get into Medicare. There are several parts of Medicare. The first part is Part A. When you turn 65, you sign up for Medicare and you get Part A Medicare. It's free. You can also get Part B, and this is where the additional coverage comes in. Right? There is MACs, which are Medicare Administrative Contractors, as well as MA plans, but who oversees them? CMS, which is the Center for Medicare and Medicaid Services. Right, so you have CMS, but you also have a wing of CMS, which is HHS, Health and Human Services, right? So we're going to talk about those. But for Medicare, Health and Human Services doesn't deal with Medicare per se. CMS, they're the parent go-to government organization that takes care of Medicare, the rules and stuff. So for traditional Medicare, you have Part A and Part B, and they're going to take care of 80% of any of your expenses in the medical field that you come across. 20% you're responsible for. So if you have a service that's $100, Medicare pays $80, you pay $20 out of pocket. Okay, that's how it works. But there is also Part C and D. Part C is Medicare Advantage, all right? That's an MA plan. That's not a MAC because they're contractors. Medicare Advantage, they hire risk adjustment coders because they are, in my opinion, the number one people, companies, I should say organizations, I guess companies that do the risk adjustment, that they got to plan ahead. They're paying additionally out for their patient. So an MA plan is going to cover parts of A and B. We already know what A and B is. Then you have Part D, and that covers the drugs for your patient. If you're Medicare and you get Part D, your drugs are covered also to a percentage, but you can also get supplemental stuff under your MA coverage to help pay a little more. Okay. In the past, what happened was back in '97, they came across Medicare Plus Choice, and you may or may not remember that. Depends how old you are and if you dealt with Medicare. But that's when they really started doing risk adjustment. So this is not something new. It was actually being done back in the 80s too, in a different form. They had different names. But in '97, that's when it really started for Medicare to start doing the risk adjustment. You may have heard of the MMA. That is Medicare Modernization Act, and that is also falls under Medicare Part D. But now Medicare Plus Choice is Medicare Advantage, right? So if somebody says that, which you may or may not hear that, but it's turned into Medicare Advantage, which is an MA plan, and the big organization or companies like United Healthcare, Aetna, Blue Cross Blue Shields, they all have Medicare or Advantage plans, MA plans. Well, Medicare, how does it risk adjust? You have your MA plan, right? And for just now on, I'm just going to say MA plan. I'm not going to say Medicare Advantage. And they are working with MAOs, which is Medicare Advantage organizations. Okay, you cannot be a part of this unless you're a Medicare patient. And age, for the most part, 65 or older, or with like end-stage renal disease, stuff like that. But don't be tripped up by a patient that is younger than 65 because they could still be on Medicare. CMS is the one who sets the rules for MAOs. But MAOs may want to, they market for you. And so as this says, they kind of sweeten the pot by offering extras. And some of the extras are they will pay for you to have a gym membership or the community health club, especially for older patients, you know, where you can go and take Zumba classes or uh, walking clubs and talk about nutrition and stuff like that. So they kind of add those as incentives, because if you're going to join our MAO, like say United Healthcare, then you can get these in addition. Little perks will be covered. So let's talk about an example of how the Medicare works as far as the expenses for the patient. We have a patient, let's say, that comes in and they're going to have a cabbage done. So that cabbage is going to cost a little more than $75,000. Well, Medicare is going to pay 80% of that. So that's a little over $60,000. And the patient has to pay a little more than $15,000 out of pocket. Right? Unless you have an MA plan. And then they cap that and they say, okay, no, you don't have to pay $15,000. That's too much. So we're going to bring that down to like $5,000. It can't be capped more than $5,000. And then if you're part of an MA plan, they may have supplemental coverage that will knock that out as well. Okay. Now let's talk about RAF, risk adjustment factor, because the RAF score is something that you're going to see a lot in risk adjustment. So your MA plans have a RAF score, and that's assigned to all of their patients. And the RAF score is generated by what's wrong with the patient. So let's go back and say that our patient A and patient B, they're both on Medicare. Let's say they're both 65 years old, right? And let's say one's a female, and the other one's a male. So A is a female with influenza and pneumonia, 65-year-old, no comorbidities. And then we have patient B is a male, 65 years of age, same diagnosis, influenza and pneumonia, but the three comorbidities, diabetes, chronic bronchitis, and emphysema, right? The RAF score is what each one of those patients are going to be assigned based on their gender, male or female, some other things about where they live, and their comorbidities or conditions. Ultimately, that's how they determine the RAF score for our patient B is going to pay out more than the RAF score for our patient A, and ultimately because of the comorbidities, right? The prescriptions are going to be different, possibly, as well as just, you know, having to take care of a patient with diabetes and emphysema and oxygen. So this is kind of how it works in a graph. You start out with your CMS. Okay, they're the ones that are going to pay, and they pay the MAO a monthly amount of money for each patient, based on male or female, where they live, and their comorbidities. And so let's take our patient A or patient B, and we're just going to use round numbers. So we're going to pay $100 for patient A every month, but we're going to pay $500 for patient B because of the comorbidities. So then that information is, that money goes to the MAO, right? And then they pay out to the providers for the services that that patient needs for the year, okay? Every time the patient does inpatient or outpatient. So they're paying out automatically $100 a month for patient A and $500 for patient B. Okay, now let's look at some other areas. We got Medicare enrolled is a monthly MAO payment, and if they need to be paid for wellness and sickness visits. All right, so that's additional money that goes in if they have those things done, like have that colonoscopy done. That's how risk adjustment works. So what are some of the consequences of how risk adjustment works? Well, ultimately, if we have very poor outpatient coding for diagnoses, then the information's not going to be captured, and patient A and patient B that we just talked about are going to both get paid $100 a month, not the patient, the MAO. But it costs $500 a month to treat, in a year to treat patient B, but it only costs $100 to treat patient A. So you see where the MAO is losing money. Why are they losing money? Because patient B's diagnosis comorbidities weren't captured. And if they had been captured with proper documentation and coding, then they would have been getting paid $500 versus $100 for that patient, right? So they don't want to go in the hole, and they have to risk adjust. Now, they may not pay, they may not use every bit of that $100 or that $500 a month, but what they do is they're banking that $500 times 12, for patient B is going to go in the coffer here, so that when that patient gets influenza and pneumonia, that money is set aside to take care of that patient. Definitely that patient's going to be inpatient, right? They're going to have CT scans. They're going to have all of these other things done to them, supplemental oxygen and monitoring that and stuff for patient B. It's going to cost more for him to be hospitalized than it is for her to be hospitalized, that you're probably not going to have a CT scan. They're going to do a chest x-ray, give them some medicine, and send them home, right? And that $100 a month is going to take care of that. But if you only have that $100 a month for patient A or B, you see where the problem is? Now, that's a problem for the MA plans. It's also a problem for Medicare, CMS, right? And it's a problem for the provider, because they're not going to get reimbursed. The money's not going to be there in Medicare. And what the MA plan is going to say, you do this to us too many times, you don't capture all of those diagnoses, and that money's not set aside properly, we're not going to work with you anymore. We're going to drop you. You have to comply and document everything, because if you don't, then the CMS is not going to give the MAO the proper amount of money, and therefore we're going to have a shortfall at the end of the year, and we're going to blame you, the provider. All right. So under documentation is a huge problem. Down coding. I know you've probably seen, you're familiar with that, and just not getting the comorbidities. And again, that's another reason why you may do full captures versus just chronic conditions that carry an HCCs. So the MAOs are accountable to CMS, but the doctors and the providers are accountable to the MAOs, and the coder is accountable to all three because you're that liaison. You're the one translating for so that the provider can communicate to the MAO, and the MAO can communicate with CMS. So how do we do that? How do we improve things? Become a document specialist, right? And doing audits. And for the most part, not only as a risk adjustment coder, especially for a MA plan, a huge part of what you do is really your auditing, right? But the provider also needs to have an auditor in, they need to be doing auditing, making sure they're meeting the MAO's requirements so that money isn't lost. It's now let's talk about the money codes. Let's talk about how we determine how much money is assigned to a code, right? And this is where we're really getting into the HCCs and the RX HCCs. Now, let me tell you what an RX HCC is versus an HCC. There's you've got like 9,000 diagnoses that are going to map, meaning they carry about 80 HCCs. So if a person has emphysema, that carries an HCC, right? And there's about 9,000 codes that can be put in these 80 HCC categories. So that would be diseases of the lung, right? If you have emphysema, and that will carry X amount of money associated to it. For RX HCCs, we got about 75 of those little categories. And there's about 4,000 codes out of all the codes that we have, diagnosis codes that will correlate with a RX-HCC. And an RX-HCC isn't a diagnosis code that's a chronic condition per se. It's a chronic condition that may not really in the long run cost the MAO too much money, but there definitely is a prescription associated to it. So hyperlipidemia, right? High cholesterol, hypertension. Hypertension is not in the long run, over a year, doesn't really cost the MAO very much money. However, if you have hypertension, you're probably on medication, right? If you are not being compensated for the medication, the patient may not take it. And so if they have hypertension chronically for too long, it'll start affecting the rest of the body, the cardiovascular system, the kidneys are affected. So that's a way to map that not only is your patient taking medication, but that money is set aside to pay for the medication, because if they don't get the medication, then we're going to have complications. So RX stands for prescription anyway. Just know that, diabetes carries an HCC, but hypertension doesn't carry an HCC, but it does carry an RX-HCC. So there's money associated to that diagnosis, hypertension. It's just a different category. You may, as a risk adjustment coder, be doing a contract where you only capture HCCs, no RX HCCs. And then the next week they can say, hey, this contract that we just pulled in on all of these capture all the HCCs and the RX HCCs. Okay. And then you may get someone that says, hey, this contract, we're going to go back and see if any RX HCCs were missed. So we only want you to capture RX HCCs. Right. Now, these are just roles that you could play as a risk adjustment coder. Right. But as you know now, HCCs and RxCCs are what you will, they carry money. They're money codes. If you look at your textbook and you go to Appendix A, there's some graphics in there. Please, please, please do not pay attention to the page numbers. Now, for the most part, yes, page 316 is where you're going to see this particular table. However, just a heads up, if the book is updated with a new edition since we did this recording, and it's not on page 316, I don't want you to come and contact us and say, oh no, I can't find it, or it's not on 316, or am I watching the right lecture? Okay, because this information doesn't change, right? So this lecture is good for several years. None of this information is going to change. And so we wanted to keep it as evergreen as possible. So just know that yes, it's probably on 316, but if it's not, or it's not even labeled as, table 6.1, don't be having a panic attack, all right? You're still getting the proper lecture and information. That being said, go look at the table on 316. And we're going to talk about that a little bit. We got a picture of it here in another slide. But we're going to see how certain HCCs pay out more money than other HCCs. Okay. For example, the HCC 173. If something carries a 173, it would be a traumatic amputation, and it's going to be valued at less than half of an HCC of 189 for amputation status. Why? Okay, now let's think about the disease process here. If you have a traumatic amputation, right, that's the care for that patient right then, lump sum of money. Okay, but status amputation, that's going to change the overall care of that patient for an extended period of time. Right? Why? Not as mobile. You've lost a lower extremity. You're most likely going to gain weight because you're not as mobile. There's also you could have ulcers develop on the stump. And just think of the disease process of what happens when a person has has had an amputation and how their life changes. Now, I'm not talking about military vets that are super healthy, that get out there. No, we're talking about Medicare patients and having an amputation, not that traumatic when it first starts, but the overall long-term care of a patient with a lower leg amputation is going to be significantly different than a person that doesn't have one. And that long-term care is going to be different from a person that's a recent amputee versus a person that is anyway, you get what I'm saying. Okay, so you have two different HCCs that deal with amputation: traumatic, which would be, like an acute, or amputation status. Now, you should understand what status and amputation status means because you're a coder, right? Make a note of that. If you don't understand the code for status amputation, you better go find it. Now, another reason why this is mentioned is because it's a very commonly missed HCC, very commonly missed. Not only is it not documented in the patient, but the coders miss it as well in the documentation, because a lot of times it'll be just up there with the where the vital signs are listed, right? You don't think to look at that. So if a person comes in to have cerumen cleaned out of their ears and they're BKA, is the doctor going to list that? Probably not. But because that's a legal document, that encounter, if it's not documented, it doesn't exist. So that patient's leg just grew back as far as documentation is concerned. It has to be documented with every encounter. Does it affect the plan of care for the ears? Absolutely not. It doesn't. However, it does for risk adjustment. You can't miss a BKA. It has to be captured for risk adjustment. Can it be documented? And will it have to be captured in the billing for that outpatient encounter? No, but it needs to be documented that it was there for the risk adjustment. Okay, so it's two different codes. So because that's one reason why the people get confused when they get into risk adjustment. They say, wait a minute, you can't document something that wasn't treated in that encounter. Yes, you can. You don't bill for it, but you want to document it because it's part of the plan, ongoing care for that patient. Does it affect why the patient was seen that day? No, it does not. However, the long haul for that year of that patient, it does. Okay, and that's why we got to train their providers to do that documentation. So let's look at the answers on that table. If you go and you reference that table, you notice that the age of a man makes a difference, and also that men tend to be less healthy than women at that advanced age, and therefore are at higher risk. So therefore, men are it's paid out more money for men than for women when you do the RAF score, right? So our previous patient, patient A is a female, patient B is a man, they automatically are going to get more different money at a certain age. That's why gender is important. So if you have a HCC of 157 for a pressure ulcer with necrosis through the muscle and tendon to bone, that pays out a lot, right? Why? They got a pressure ulcer, right? Pressure ulcers take a long time to heal. You've got necrosis. They're going to go in and have debridement and surgery. What happens when you have necrosis of a pressure ulcer? You're looking at possible gangrene, right? And then you can look at, depending on where it's at, amputations and stuff. That is going to carry a lot of weight. Most amputees, where it's stating here, are due to a chronic condition, a comorbidity. Right, so traumatic amputation, it's not. He had a motorcycle wreck, he lost his leg. Traumatic amputation. No comorbidities, he's doing fine. All right, now, does he not get around as well? Yes, all those things, you're probably going to gain some weight, blah, 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 but the fact is, because we know the disease process, because of the statistics that we've captured in the past with our coding, because that's why we code, is for statistical purposes, we know that most amputations that a person has is because of something like diabetes. Therefore, that HCC for status amputation is going to get paid more money because probably they have comorbidities, right? The RxHCCs, I kind of already explained to you. It really doesn't make a difference on age and stuff, but there are certain that pay out higher and lower. So the question that's asking here, the first two questions, let's just read those. What is the highest paying RxHCC for community, non-dual, and aged? And what's the lowest? Well, the answer is a 16 is the highest and a 206 is the lowest. So you need to go in and look at the HCCs, the RxHCC model, and see what a 16 is and what a 206 is. Now, the next question, what reason could there be for an HCC for HIV/AIDS to be significantly lower than the RxHCC for HIV and AIDS? It's the medications are just so expensive, okay? And then the cost for both the encounters, the tests, and stuff like that, and hospitalizations for a patient. So an RxHCC is very expensive, but they're very expensive. But again, it doesn't matter that it's the HCC or the RxHCC. All that stuff that we've already talked about plays a factor in accumulating how much money set aside for that HCC. We're still looking at Appendix A, and we're looking at that table, both the HCC table and the RxHCC. And really what they're wanting you to understand is the difference between HCCs and RxHCCs, the fact that if you have an RxHCC for the, like HIV, it's still going to pay out less than the HCC or whatever condition. They may not be the same, or it may not make sense to you because they factor in several things, and you have to understand the disease process. And once you do, then you understand why it pays out more or less than what you would assume. All of this and the statistics that we've gathered allow us to come up with a RAF score. Now, you may or may not be involved as a CRC in determining RAF scores for a patient. Right? You may be what I call in the trenches coder, where you're just capturing the HCCs, whether it be RX or not. Or now with HHS, it could be an HHS HCC. Okay. But you have to be able to understand how a RAF score works. And this is more of the business side of risk adjustment. So again, I say in the trenches and the business side, you have to know both sides. And whatever role you take is, up to you, where that path takes you. But as a CRC, you have to know both of them, because as a CRC, you're the specialist. Now, also, we've got to talk about trumping. Trumping is a term, and I think of it like playing cards, right? If you're playing a game of poker and you say twos or trump, or whatever you're playing, that means that a 2 captures whatever's laid down. Okay, so it's the highest level. And that's the same thing it is with trumping with risk adjustment. We use that term to say that a patient with diabetes is trumped by a patient with diabetes and complications, acute complications or comorbidities, right? So let's look at this, and I'm sorry that I made this a PowerPoint and it kind of, your slide deck kind of got messed up there. So this should be common sense to you as far as the disease process is understanding. Metastatic cancer with acute leukemia, okay, carries an HCC of 8, okay, and that 8 is going to trump HCCs of 9, 10, 11, and 12. A 9 is going to trump 10, 11, and 12, but it isn't going to trump an 8. So in other words, it costs more to take care of a patient that's an 8 than it does a 9. Now, do all of the numbers go consecutive like that? No, they do not. Do not let that trick you, right? As a general rule, kind of, you see that, but that's not the way it works. So is an 8 always going to trump a 9? Yes, in this category. Okay, so but don't think just because the number's lower that it carries more weight or it trumps. Now let's look at the RxHCC2. We are looking at a chronic myeloid leukemia. The medicine it takes to take care of that patient is going to trump 16, 17, 19, also 96 and 98. You have to go look and see what the RxHCCs are for 96 and 98. All right. An 18 trumps a 19. Okay. And that's for the RX. The same way it works with non-RX, but the regular HCCs. But don't think that the sequence of the number makes a difference, because it doesn't always do that. Categories change, and for the most part, they don't change, but they can change, and it depends what category you're in. Okay, so a person can be an 8 and a 110, but that doesn't mean the 8 trumps the 110, because the 110 is a specifically different type of diagnosis. Okay, so these are categories where they're similar, lung conditions, things like that. Synergistic diseases. If you don't know what synergistic means, go look it up. It's all working together, and there's synergistic medicine. It's really cool. We did that in our pharmacology course. If you haven't taken that, it would be a great thing for a risk adjustment to have a coder to know that pharmacology. So you can take that pharmacology course, and you'll see synergistic disease medications in there. So how do diseases interact with each other? Though this is a pretty classic one. You got an example of CHF and COPD, right? COPD is the lung, CHF is the heart. When you have them together, then of course the outcome possibilities for that patient is at a higher risk. Right. It's bad enough to have CHF, but if you have CHF and COPD, the lungs are not providing a proper amount of oxygen, and the heart is already compromised. Right? You already have types of heart failure. So the outcome for that person, those two different diseases truly interact with each other, and you need to understand that in the disease process. Now, don't freak out because you're just getting started in the course. It's like, how am I going to learn these disease processes? We have the pearls, right, which is like a little study guide for all of these disease processes. We tell you everything you need to know about CHF, everything you need to know about COPD from the standpoint as a risk adjustment coder. Right. And they just behoove you to go through those as a coder in general, because when you understand the disease process, you're able to code faster and to a higher specificity. Right. Let's see, according to, and again, don't pay attention necessarily to page 320, but that being said, look at page 320 and look at the disorders that you'll see there. And it asks you, what about psychiatric disorders? How do they interact with other conditions? Because you think, okay, well, that's the brain. Well, you can ask yourself that, and as well as like pressure ulcers. And the fact is if you have substance abuse, that is definitely going to affect a patient with COPD, CHF, or seizure disorders if they have epilepsy and stuff. Yeah, you think, okay, well, what are you talking about? Substance abuse. Smoking, just generally smoking, interacts, because COPD, you don't get good oxygenation in the lung. And if you didn't know, cigarettes are vasoconstrictors, and so therefore it clamps down the vascular system. That's really bad for a patient with CHF. It's really bad for a patient with COPD too. So not only are you compromising your lungs with the smoke, but you're also compromising your vascular system with the nicotine. Same thing with seizure disorders. You have to understand the disease process and the comorbidities and how they work together. Sepsis of a stoma will definitely interact with pressure ulcers, right? So again, understanding that is so important. Here is a little example that you can find in your book, and I love the way they've got this divided up. Notice that says non-dual, a term used to describe Medicare benefits who are not enrolled in Medicaid or Medicaid beneficiaries who are not enrolled in Medicare. Okay. So in other words, that patient doesn't have other insurance coverage. And they're showing you a RAF score of a 66-year-old male. We have CHF, prostate cancer, diabetes, complicated, which is different than uncomplicated, PVD, he's got a BKA, and he's morbidly obese, and he has interactions with his CHF and DM. So he carries a RAF score of 2.400. And how does that translate into money? Well, it ends up being $23,000, a little more than $23,000 annually that's set aside for that patient. Okay, and of course, that's not even including the RX. Okay, so this is saying that they have a capitated rate, meaning $800 a month, and the MAO is going to receive $9,600 for a year for that patient. But multiply the capitated rate, so what the patient is getting capitated, by the 2.400, because that's his RAF score, and then it comes out to a little more than $23,000. Okay, so it's more money that's set aside in the coffer for that patient, so that we know that his needs are taken care of. Here's another one, and it shows you the difference with Part C risk factors and how it works out a little bit differently. So you've got Miss Jones and Mr. Jones. Oh, we'll say wife. So we have 70 and 92. I think that's funny. Martha lives at home, but Matthew is disabled and lives in assisted living. So we have the score for the age. Definitely, he has a higher age. They both have COPD. They both have CHF. But see how the score is different from him versus her, because she's a female and she lives at home. And then they're in an institution, so therefore he gets a score for that, and the total RAF score for her and him. And then that will be used on top of what the MAO gets to project a total amount set aside for a year. Now, this is the business side of your risk adjustment. You do have to understand this. You don't have to have it memorized. You just have to understand how it works. Okay, they're not going to necessarily, when you take the CRC, make you come up with that 0.963. No, they're not going to. They're going to say, you know, who ultimately they're going to phrase a question: who gets more money? Well, it's him. And honestly, it makes sense, right? You don't even necessarily have to know the number, but the number carries weight. How do we submit all of this information to CMS? Well, it's used through RAPS, and that's a risk adjustment processing system. So if you're a risk adjustment coder, you're collecting all these HCCs, you're collecting diagnoses, you're converting them over to the HCCs, and then you put them into your program, and boom, you send them off to CMS. And then they do all the calculating and everything. They do sweeps certain times of the year. Risk adjustment coders could work in spurts. There's 3 main pulls in a year, and so they try to get contracts all finished up. You can work year-round as a risk adjustment coder, but depending on who your employer is and how many contracts they have and stuff like that, then you may or may not. So big companies like Optum, who have the UHC contract, United Healthcare contract, who's an MA plan, of course, they may work all year long, because they're constantly got things that they're fine-tuning and doing. And that's why you may be asked to code one way one week, and the next week they say, hey, you know, now I need you to capture XXX, you know, and then next month it's going to, you know, they call you up and say, oh, nope, no, why, you know, things like that. So be very aware of that. But you do need to know that MAOs are held accountable for the content that the physician and the hospitals put out. So CMS is looking to the MAOs to give them the proper information. And the MAOs are looking at the providers and the facilities to give them the proper information. So the MAOs carry a lot of power because you kind of think that the thumb of CMS is on them. So you never want to mess with an MAO. But they are very good about giving you incentives and training, lots and lots of training, because it behooves them to do that. So whether you work for an MAO or you work for a physician or a facility, your role as a risk adjustment coder can be many hats, but ultimately you need to know the chain. And I've already told you about what happens if you don't have the right accuracy and getting the complete diagnoses for the documentation that's given, and the providers are not trained to do this. We had a couple years ago, Joanne, who works with us, has a billing company, and that her daughter runs now. And quite honestly, when it really, right after the ACA came out and they were forced to do this, and risk adjustment really played a huge part, they had been getting incentives, and she and the coders have been telling the doctors, you're not capturing everything. And because you're not, you're going to get penalized. And I think one doctor one year got penalized $50,000, $50,000 less than his check. That's an employee. That's the light bill, right? Because the MAO is not going to pay you properly if you don't get everything documented. That's why it's so important in risk adjustment to have to get the CRC, to be skilled, to understand the whole process. This is a very fast-growing niche of coders. It's a specialty where it's pretty easy to get hired as a new coder, but you have to develop your skills. And a lot of those skills are done in the trenches, in there doing the work. So how do they validate the audits or the information that CMS gets? They do a RAD-V audit, and that is a risk adjustment data validation audit. CMS audits them. CMS audits the MAO plan. So they will say, you need to give us a copy of the documentation so we can validate it. So you could be a RAD-V audit risk adjustment specialist. So you're working for CMS to go in and audit the MAO plans. The MAO plans are going to audit their providers and their facilities. Okay, so auditing is a way of life as a coder, but it's extremely important in risk adjustment. So you just have to accept that auditing is a way of life, and you need to embrace it and not have a chip on your shoulder, and be able to take constructive criticism, because it's quality over quantity. They want you to have a 99% accuracy rate. There's too much money involved in risk adjustment. Also know that they do have some repayment plans. If you have a RAD-V audit come into your MAO and they see too many mistakes, you owe them money. The MA plan. So who do they come back? Then they go back on the provider of the facility, and they get the money from them. Right. So you want to be in good relationships with your MA plan, because CMS is breathing down their neck. We need to talk about 5-star quality ratings. And the thing about 5-star ratings is knowing that this information is public. The MAO are, you can pick and choose who you want. So if you work for Medicare, if you're a Medicare patient, you can pick which MAO you want to go with. Do you want to go with United Healthcare? Do you want to go with Aetna? Do you want to go with Athena? Do you want to go with Blue Cross Blue Shield? And they will give you incentive. The more clients they have, then and the sicker the clients they have, the more money they have to work, right? And so there are incentive quality ratings for MAOs. And this is why they also have they pay for you to join your community health center or take, water aerobics, things like that. They want you to be healthy because they get money for you maintaining your health. They don't want your health to go down, and for you improving your health, all in this quality, 5-star quality. So if an MAO, let's say mega MAO got a 5-star rating, but beta MAO has a 3-star rating. When you look at that, you're going to know who you want to go with. Well, you're going to want to go with the first one, right? Because obviously they're doing well. And what are they tracked on? They're tracked on customer service, the extras that they give to their people, as well as the information being collected. All of that plays a part, and that's translated into bonuses for those MAOs, which means that they can turn around and give those extras to their clients. What is the risk pool? Well, that is set up by the Affordable Care Act, and it also affects it's working with HHS. So now we've been talking about CMS. Now we're talking about HHS, which works very much like CMS HCCs, but it is different because Medicare pays for 65 and older, right? Whereas Medicaid and other commercial insurances pay for all age groups. So we're going to have babies being delivered. We're going to have pediatric coverage that needs to be done. Perinatal, obstetrics, big area. So you're not going to find obstetric HCCs in CMS HCCs, but you will find them in HHS HCCs. So more categories. Plus, they don't risk adjust from a previous year. They do the existing year that you're in, right? And so that's a little bit different. They also do audits, but they're called IVAs or SVAs, but they still have, it pretty much works exactly the same. So this is how the risk pool works. You have the federal government is taking the tax money. They've got a patient enrolled in Part A. They go and have their wellness visits and everything, and so that is the encounters for the patient. But they also pay a monthly fee in, all right, to also have those done. But the risk pool, the risk scores are all plans that are compared together. So they know how many obstetric patients, because of the statistics, how much they need to set aside, especially obstetric patients that have C-sections or obstetric patients that have comorbidities like gestational diabetes, et cetera, et cetera. So that's how it works. And so the ACA runs that. Ultimately, they're the ones that set the rules that guideline that. And if the ACA goes away, don't worry, that's not going to go away. It's not going to change. It's almost like, think of it as prohibition. Alcohol was still there in prohibition, but because it was the law, you take the law away, the alcohol's still there, right? So parts of the ACA, whether it's struck down or not, those benefits will still apply to risk adjustment. The disease burden is always with risk pools determined by the diagnosis code. How do you get the diagnosis code? With the documentation, and the coder is responsible for translating, reading the documentation, so it has to be documented, translating the diagnoses into a code set that can be understood by everybody, and that statistical purposes can be tracked. So wrapping up, this is what you need to be aware of. Okay, you know the difference between the HCCs and the RX HCCs. You know the difference between HHS HCCs and CMS HCCs. Okay, they're different tables. The money is set aside differently, and the equations that they use to determine them are different. We already established that. But what you know everybody else out in the field that are coders, the clinicians, the providers, the facilities, they don't quite get it, right? They are still real slow to it's not like they're getting on the bandwagon. It's just they've never had to really pay attention to this before. And even though it's been around since in the 80s and the 90s, it didn't affect them, but it does affect them now, and even more so as the years go by, because we're switching the pendulum from it being the CPT that is why we're getting paid, but the diagnosis, right? Pretty much everything risk adjusts. Whether that's how you get paid or not, it still is going to risk adjust, because they're making that they're making that understanding of how beneficial it is to have that budget. But it's all based on the risk adjustment coding and coding correctly, documentation and coding correctly. Again, that's what you have, that's your main focus, is being able to code correctly. Don't worry, you know, you don't have to memorize this stuff. You just need to be aware of it, right? You're not going to have to you're not going to have to memorize the HCCs of the RX HCCs. Are you going to know a lot of them? Yeah, if you're in there doing the I used to have a lot of them. I could tell you that, you know, let's see, the RX or an HCC for diabetes is a 19, but if they have a complication, it's an 18, things like that. You know, you just, because you see it again and again. And I used to know what prostate cancer was and all these ones that you see again. But do you have to have them memorized? No, you don't have to know what the REF score is. You know, it's all there for you. What you do need to know is how to code properly. You need to know chronic conditions, and you need to know things that support the disease process. Okay, those are what you need to know, and understand the difference between poor and proper documentation, and how to read all types of documentation. What are the goals? Well, it's not only to code to the highest specificity and accurately, quality over quantity, but also you need to be able to educate. Right? Now, you may be asked to explain why we have to do what we do, right? And so you have to learn to be able to explain that in a manner that's not offensive. But education is a big part of what you're going to do as a risk adjustment coder. You want to improve the quality of the documentation, and you want to assist those providers who are not trained to document for risk adjustment, as well as just diagnoses in general. You're going to help them. You're going to be their helpmate in going forward. So that wraps us up. Wow, this was a lot of information, I know, to take in. It's such an exciting course. You're going to fall in love. Do not be intimidated. And if you have any questions, make sure you know that all the students tap in to ask your questions into the CCO Club in your Student Support Hub. If for some reason you're watching this and you're not a student and you have questions, go to the CCO Club and we'll be more than happy to answer them for you. Even if you're a student and you haven't liked and subscribed our YouTube channel and Facebook page, you need to do that, because there's additional education that you're going to find very beneficial to you. All right, guys. Thank you, and have a great rest of your day.